Hey everyone, Assalamu alaikum and welcome to another episode of ECREMtalks, a podcast where we discuss emergency medicine core concepts and the impact of the specialty in the UAE. I'm your host Anzal Rehman, and today's episode is the second part in the series entitled Cardiac Arrest, Can We Do Better? Today we're going to be continuing our discussion on nuanced aspects of cardiac arrest care that hold some promise for improved resuscitation. Once again, we would like to remind our audience that none of the topics discussed on here are to be considered as official recommendations to change current standard of care in cardiac arrest. Rather, we will attempt to dive into interesting ideas and discuss what areas we believe could hold some exciting potential and could lead to innovative techniques in the future. Joining us again for the discussion is Dr. Laila Hussein from the Sheikh Shakhbout Medical City.
Hello, Anzal. Thank you for having me again. It's really a pleasure for me to be here.
It's our pleasure to have you. For those of you who are just catching up, in our last episode, we discussed manual pulse check reliability and the advantages of using point-of-care ultrasonography or POCUS to enhance pulse checks during cardiac arrest, as well as their use in assessing and visualizing cardiac rhythms. On this episode, we're going to be talking a little bit about refractory VF, or ventricular fibrillation, and some emerging treatment modalities for the same, as well as some further concepts on ultrasound implementation and in the flow and how it applies to the flow of the resuscitation process. We'll start with the refractory VF that I mentioned earlier, or more specifically, ventricular fibrillation that's refractory to shock. I guess the first question really is, what does that even mean? How do you define refractory VF?
Refractory VF refers to VF that persists despite shock delivery. Therefore, you can call it shock-resistant VF. Now, the number of shocks that you need before you call it a refractory VF varied. In some studies, it was 3 shocks or up to 6 shocks. But the European Resuscitation Council has defined refractory VF as fibrillation that persists after 3 or more shocks. It occurs in up to 20% of patients who present with VF, and it's important to differentiate it from recurrent VF. Recurrent VF, on the other hand, is the one that comes after it has been terminated. What we can say pretty confidently is that the longer the patient is in refractory shock, the worse is the survival to hospital discharge.
I kind of like the idea of 3 strikes, and you can call it that, refractory VF. Just makes it a lot easier to remember. And so just so I'm clear, this is 3 in a row, and so that would be refractory. But if it was alternating in between with asystole or PEA, that would just be a recurrent VF. Am I correct?
Yes, you're spot on.
All right. So I guess that kind of makes sense. You can say that this VF is something that we can probably bring back because it just stays there for 3 times in a row. But so the longer you let that stay, I assume the worse it's going to be, which makes this quite daunting if you see it. I mean, I know that essentially you could potentially go on and on with shocking that fibrillating heart until something happens one way or the other, for better or for worse. But could we potentially do better than just, keep on shocking the guy and hoping for the best? Are there any known techniques that we can tackle this specific type of presentation in the arrested patient?
This is a difficult situation because you can go on giving shocks for a very long time and you're stuck because you're just doing the same thing over and over again. That's not working. And at the same time, it does not feel right to declare time of death for someone while he's still having VF. So there are actually few innovative interventions out there that are not yet supported by strong evidence, but some of them show promising results. So the first one is double sequential defibrillation, or what it's called as well is dual shock therapy. This technique involves delivering shock to the patient with 2 defibrillators simultaneously. One set of pads is placed in the standard anterolateral location, with right pad under the right clavicle and the left pad on the left lower chest. The second set of pads is applied anterior posteriorly, with 1 pad in the middle of the chest and the other in the corresponding area of the back. Basically the same way you would place pads in pediatric patients. Alternatively, the other option is to place the second set of pads parallel and left to the first set. You will then assign 2 nurses to defibrillators to charge them both to 200 joules, and you will deliver both shocks on the count of 3.
So that sounds pretty interesting. I mean, if you think about it at a physiological point of view, you've got this heart that's going haywire, and normally what you want to do is put that voltage through it from those 2 vectors that we usually do to try to slap it back in action. And essentially what you're doing here kind of makes sense. You're just adding more vectors, a little more energy, so that that aberrant rhythm kind of corrects itself, and there's more chances of that if you have more directions through which that electricity is flowing. So it's an interesting concept. It sounds pretty exciting, but do we have any evidence around this?
Majority of the data we have on double sequential defibrillation, or let's just call it DSD because it's mouthful, it comes from EMS literature over the past 6 years. It is important, though, that out-of-hospital cardiac arrest prognosis differs from the in-hospital cardiac arrest. And we also know that the longer the patients are in VF, it is harder to revert them. From the current literature that we have only one randomized control trial called the DOSE VF study, and it's a pilot study that was published in 2020. This looked at 152 patients in the pre-hospital setting assigned to either standard defibrillation, a vector change approach in which they changed the pads into anterior-posterior placement, and the DSD. Using vector change approach and DSD was found to be feasible. In their outcome, 66% of patients had VF termination in the standard group versus 82% in the vector change and 76% in the DSD group. So both the vector change and DSD did better. However, this study just shows us that the implementation is feasible and safe, but the RCT is currently ongoing and is on its way with about 900 patients set to complete in 2022.
Wow, that sounds promising. I had heard a lot of ruckus and rumors about this DOSE VF pilot study, and I think it made its drifts in the media as well. It sounds pretty good. It's for a start to say that it's feasible. And while we're waiting for that RCT with the 900 patients, which does sound optimistic, do we have any other data to say that this improves outcomes in any way? I mean, you said VF termination is a little bit better, but patient-centered outcomes-wise, what are we looking at?
So currently, the AHA guidelines do not recommend the routine use of DSD, and they have referred to a recently published systematic review by Charles Deacon that has showed that DSD patients did not do better compared to standard defibrillation. Similarly, the ILCOR group has reviewed the evidence on DSD, and they have made a weak recommendation against the routine use of double sequential defibrillation strategy. Now, we have to discuss the systematic review from which this evidence comes, because it has included 9 studies over the past 6 years. And from these studies, only one is a randomized control trial, which is the pilot study. And all the other studies were case series or cohort studies with a varying degree of bias. What we can conclude from this systematic review is that among the 326 patients where DSD was applied, there was no reported harm or damage to defibrillators.
Admittedly, I'm considerably less excited now. It doesn't look like the outcomes were very impressive. But I guess the good news here is the fact that there wasn't harm to the machines. And I think I speak on the behalf of our pre-hospital staff and our nursing, and the ones that are going to get a little bit more anxious when we ask them to put 2 machines together. And it kind of makes sense. I mean, you don't want to fry the all that voltage going here and there. So integration-wise, applicability-wise, I believe this at least points towards feasibility more than anything else. So if in case it does get integrated into practice, I believe we can at least say that it's safe enough to use without damaging our resources. But besides keeping that in mind, I guess the big question there is, in light of the evidence that we've discussed and the current guidelines of the AHA and ILCOR, what would you, Dr. Laila Hussein, evaluate as the use of DSD or the potential use of DSD in refractory VF?
I believe at this time we do not have enough evidence and enough good randomized controlled trials to recommend it as a standard practice. However, in the near future, we might be looking at more evidence or more results that show a better outcome. Remember, absence of evidence is not evidence of absence.
Well said. And thankfully, we do have that one study that you mentioned with the 900 patients underway. So here's to hoping for some more definitive facts and evidence from that. So, all right, moving on. I mean, that wasn't entirely that promising, but I have heard a little bit about this beta blocker called esmolol, and we always try to find a use for esmolol somewhere in literature sometimes. But I heard that in ventricular fibrillation there was something mentioned about this in literature as well. I mean, is there evidence of use of esmolol in VF?
So the evidence on esmolol is really, really tiny, but it's worth mentioning. Esmolol is a fast-acting medication that increases myocardial threshold for VF. Unlike epinephrine, esmolol is a sympatholytic, which can block the catecholamine surge during VF. The current recommended dose that we know is 500 micrograms per kg IV bolus, followed by a drip of maximum of 100 microgram per kg per minute. This evidence is coming from two small trials from the United States and Korea, where they recruited 25 patients in one study and 36 in another. Patients who received esmolol had 50% survival to discharge rate compared to 10% in the control arm. And what's great about is that 50% had better neurological outcomes as well. So currently, we do not have any strong evidence to support it, but after 3 shocks, 3 doses of epinephrine and 300 milligrams of amiodarone, it's worth a shot.
That's interesting. I'm tempted to love the fact that this is one of the only, if not the only drug to actually have better or good neurological outcome in an arrest study, because that's so rare, if anywhere in literature. But I mean, you have to keep in mind, like you said, this is a tiny number of patients in very small, limited studies. I believe you said it was only 6 patients who received esmolol in one study and 16 in the other. That's barely a number, and leaving things quite possibly to chance with these outcomes. But suffice it to say, as a physiological intervention, the theory seems pretty promising and kind of exciting, to be honest. But I believe a lot more data on this would be brilliant moving forward. So looking forward to see what comes out of evidence surrounding esmolol. But yeah, I guess it's great first steps is the best I can probably endorse at this point. So let's kick things a bit further with a case. Dr. Laila, let's assume you get a call. A 47-year-old male has been found unconscious, seen by the EMS, identified with an initial rhythm of PEA. A downtime of 7 minutes was ascertained, and they began CPR. He's undergoing CPR as per the paramedics on the phone with you, and the ETA to your emergency department is 5 minutes. Given that, understandably, there can never be a perfectly ideal scenario in reality. Given the information I've given you, and assuming you have exactly the emergency department setup that you want, or how we wish we would, how would you prepare your team, your department, and plan your workflow for this suspected cardiac arrest case?
As with any cause that we attend to, Anzal, good preparation is the key for an organized and successful resuscitation. In an ideal setting, as you said, you would need to have at least 2 or 3 physicians running the code. 1 for the airway, 1 for the ultrasound machine, and 1 to lead the code. The one who's the team leader should not be the same person as scanning. Remember, the one who's doing the ultrasound should be ideally the most experienced user. So this should be someone who has not just completed the basic ultrasound course, but somebody who has been doing lots of scan on live patients, knows how to get heart windows quickly, and has an experience and interpreting the images quickly as well. You want to prepare your ultrasound machine before even the patient arrives. So you want to plug it into electricity, select the correct presets, get the gel ready on the machine, and have a towel ready in your hand so that you can wipe the gel off the patient as soon as you're off the chest. You also want to communicate with your nurses of what you're going to do so that they understand that you're going to use ultrasound and they understand that you should not be breaching the 10-second pulse check. So ideally what I do is I always talk to my recorder and I tell them that I want them to give me a countdown before the pulse check. Okay, so they will tell me 3, 2, 1 pulse check. So we know that we're starting the pulse check, we're starting to scan. And I also want them to give me a countdown while we are doing the ultrasound. So I will ask them to count out loud 10 seconds. So we make sure that we do not breach 10 seconds.
All right, sounds good. So let's assume you've got this ideal setup. The patient arrives in your emergency department. The nurses have attached him, moved him to the resus area, attached him to the monitor, and you identify the rhythm as an organized rhythm without a pulse or a PEA. How would you proceed now?
So priority when the patient arrives is to transfer him to our resuscitation bed, establish good quality CPR. If we're going to intubate the patient, is to do the intubation, establish an IV or IO access. Now, if I'm the one who's doing the ultrasound, I would want to get the heart windows even before the pulse check comes. So you can actually scan the heart while the CPR is ongoing. And this is actually easier to do than it sounds. With manual chest compressions, the easiest view to use is the subxiphoid view, because you're sort of not interrupting with where the hands should go on the chest. But if the patient is receiving CPR through mechanical chest compressions, you might want to attempt also the parasternal long axis or even the apical view if you can fit your probe under the machine. And sometimes these views are easier because the stomach is full of air, and which would obscure your subxiphoid view. Now, once I get a good view of the heart and I make sure my presets are ready, I will just wait for that 3, 2, 1 announcement from the recorder. And I will have the probe in my right hand and towels in my left hand, so that after scanning, I can immediately wipe the gel off and the hands come back on the chest and it's not slippery. I will also want to press the record button, because while we're scanning, usually those 10 seconds are not enough for us to sort of interpret what's going on with the heart. We're trying to focus of getting the good view, but it's hard to actually read of what's going on. So if you press the record button, you can go back once the CPR restarts and view the videos that you've saved, and then look for possible reversible causes of arrest. Remember, if you don't succeed in getting a window, you should not play around with your probe trying to get a window. Only one window per pulse check. So if you don't succeed, you may want to wait for the next 2 minutes for the next pulse check to get your window. You don't want to spend the entire resuscitation looking at the heart every 2 minutes. The value of using ultrasound, as we mentioned in the first episode, is initially to look for reversible causes of arrest. And then I might use it again coming to the end, towards the end of the resuscitation, as it might help me prognosticate where this resuscitation is going to. Remember, that would be in conjunction with other factors, other bedside tools, as for example, the time of arrest, whether it was witnessed or not, whether it's out of hospital arrest or not, and using other bedside tools such as ETCO2 when his blood gases.
That seems to make quite a bit of sense. There's one thing you mentioned that is a little bit intriguing. You mentioned you placed particular emphasis on the 10 seconds, and you were establishing parameters in place and keeping a recorder nurse and having the 3, 2, 1. And it's quite interesting to note that you've put so much emphasis on this 10 seconds. Is there any particular reason why you're focusing so hard on disciplining these 10 seconds?
In 2017 and 2018, 3 studies came up that showed that using ultrasound during CPR might actually delay chest compressions. There was an important study by Clattenburg, where in 24 patients, they observed the time it took for a pulse check with and without ultrasound. And they find out that using POCUS was actually 6.1 seconds longer than without the ultrasound. This was similar also in the other study by Hughes, where the POCUS time where hands were off the chest was 21 seconds as compared to without POCUS, which was 13 seconds. This evidence by no means should discourage us from using ultrasound, but rather highlights the importance of proper training and self-discipline to adhere to good techniques and to minimize hands off chest time.
Okay, so that's pretty significant, and I wasn't aware of this significant delay when using ultrasounds, and I can understand now why a lot of different people informally sometimes are not so keen on incorporating into their resuscitation practice. But I completely agree with your perspective on better discipline and optimizing our time so that we can sort of achieve the best of both worlds, so to speak, where we've got this amazing imaging modality that we can sort of get answers from, but we don't compromise our hands-off compression time, like you said, and thereby we're sort of protecting our cerebral perfusion. So that makes sense in that aspect. But there was another question that I had, if you'll bear with me. So you said towards the end of our previous discussion about prognostication. You mentioned that you could use this towards the end and in subsequent pauses for pulse checks to not only look for reversible causes, but also to figure out where your resuscitation is leading. So I just wanted to ask you, how does this cardiac standstill that you mentioned help you prognosticate the patient?
So we know from the current evidence that if you see a cardiac standstill, those patients usually do worse than if you see a cardiac activity. Now, in a recently published systematic review and meta-analysis, they attempted to answer this question, and they've looked at if point-of-care ultrasound is a reliable predictor of outcomes in atraumatic non-cardiac arrest. From this systematic review, we know that if you see cardiac activity on POCUS, this has a pooled sensitivity of 60% and a specificity of 91. Whereas if you see a cardiac standstill, the sensitivity for predicting growth was 26% compared to 76% with no cardiac standstill. Which means that patients with no cardiac activity are much more likely to have a poor outcome. Keep in mind that even with no cardiac activity, some patients still survive. So it should not be the only factor and decision maker to continue or terminate a resuscitation.
So that about brings us to the end of this episode of Cardiac Arrest, Can We Do Better? Where we talked about the concept of refractory ventricular fibrillation and how double sequence defibrillation sort of adds to that, or possibly could add to that management in the future of cardiac arrest. We mentioned how esmolol could play a potential role in the future based on a few optimistic but admittedly limited studies. And we move forward with a sample case scenario where Dr. Laila showed us how the ultrasound can play a significantly important role in augmenting the care during that resuscitation process. She talked a little bit about workflow and how to optimize your time management, and how this is ultimately one of the most important things to help your patient and help your decision-making process. Finally, we spoke a little bit about prognosticating the patient and how, again, POCUS can help you determine certain aspects of care, especially when there has been other factors in play determining poor outcome for that patient. That's all the time that we have for this episode. Dr. Laila, it's been an absolute pleasure to have you back on with us to contribute to our podcast. We thank you so much for your time and for your interest in helping residents in the UAE learn more about cardiac arrest care.
Thank you very much, Anzal. The pleasure was mine.
And thank you everyone else for listening. See you all next time on ECREMtalks.